Um, appreciate the invitation. And coming to you from Chile, Toronto, I actually visited Iran in 2001. I was a speaker at the Iranian Institute for Industrial Engineering, the first one, and I loved it. And none of my expectations about Iran uh, were all of them were blown away. It was a lovely trip. That people took great care of me. And then I brought one student home with me, Somaya Sadat. She came. She was an undergrad at Sharif, and she did her master's with me, and then her PhD. She went back to Tehran and taught for a few years. She was a professor at um, in Tehran, and then she's now back in Toronto. Um, so let me tell you about this talk. I've been working in healthcare, almost exclusively in healthcare for 30 years, and trying to implement operations research and industrial engineering. And it's been difficult to be able to do that. And so I decided um, to put this talk together a few years ago, talk about some of the challenges that we have in industrial engineering in implementing our models in healthcare. And I gave this talk in Athens and virtually at the Euro conference, the European OR Society, 2022, so last July. And I've submitted a paper for publication describing the results to the EJOR. I'm still waiting to hear back. I'm happy to share copies. Well, assuming it's been accepted. There's been a ton of research on OR in healthcare. Very little has actually been implemented in a sense. And this talk is some of the things that I've learned, and with examples. I don't know if anyone's familiar with the Calvin and Hobbes. Calvin and Hobbes cartoon is a philosophy cartoon. So he says, so Calvin said, let's try this path over here. I don't see a path. We'll make a path. Oh boy, change is invigorating. If you don't accept new challenges, you become complacent and lazy. Your life atrophies. New experiences lead to new questions and new solutions. Change forces us to experiment and adapt. That's how we learn and grow. Whoops, here's a new fresh challenge. I'll admit it opened up new horizons. The problem with new experiences is that they are so rarely the ones we choose. I feel smarter already. I love Calvin. So that in healthcare, there are lots of examples at operational levels of using operations research. People have used operations research for nurse scheduling, operating room scheduling, home care, nurse routing, etc. So a lot of the operational problems have been implemented. But I decided several years ago that I was doing a lot of essentially nickel and dime, some of the simpler, less, saving a few dollars here and there in a billion-dollar industry. And I wanted to have more impact at the tactical level, the strategic level, the policy level, and wanted to do something more on that. And only 5 challenges. I gave this talk for the first time several years ago in London, England, and for an NHS group, the National Health Service. And they asked me to talk about challenges in implementing models. And, it's the organizer, a fellow by the name of Terry Young. he edited. I said my problem was going to be challenges, and when he put out the program, he said the top 5 challenges. He edited my thing, and I'm glad he did, actually, because it actually made me focus on some of the key ones. It's really easy to list 20, 30, 40 challenges. I can talk about problems for hours. There's a paper by Sally Brailsford and others talking about the challenges of implementing models. And it's a long, boring list. And now, when I had to break it down to 5 key ones, it actually incorporates a lot of the other things. It's a lot easier to remember my list, I think, and it's a lot easier to focus on what the issues are. So I thank Terry Young for that. And I'm going to focus on the issues with the healthcare industry. I'm going to focus on the challenges. How do we convince healthcare administrators, policymakers, clinicians, nurses, etc., to actually use our models? So I'm not going to talk about the challenges of creating a good model. I'm going to assume that you can do that. You have learned how to do that. I'm going to ignore the external factors, things you can't control, regulations, policies, competition, etc. And for each one of my 5 challenges, I'm going to give 5. And for each one of them, I'm going to give 3 different examples of from my own work or my colleagues' work. And we're going to look at some successes where the challenge is, we've met the challenge, some failures where we missed the boat completely, and then some mixed results so I'll give you 3 examples for each one. And we shall see. Here's a cartoon a friend of mine in the Netherlands sent me. Open mic night at the hospital, and there's Mike. That's me racing down the hall. And some days I feel like that. Some days it actually, when I go into the hospital, the answers, the solutions that I come up with are not always welcome. And I'll give you a couple of examples in a minute. Okay, so the first one, the first challenge we're going to look at is that we really need a crisis. We need to be addressing a real problem. In North America, we talk about a burning platform. The burning platform, there's a crisis. We need an immediate solution. And we also need a crisis where operations research or industrial engineering is a viable option. Okay. And for a real critical problem. Now, unfortunately, people will find the time, they'll find the money, they'll find the data, but they also need to believe that your model will solve their problem. Okay? And unfortunately, with a crisis, people often need a quick answer, right? So it's hard to work with an urgent crisis. I really need one that provides time for students to work on a problem, unless we already have a tool developed. So I have to have tools ready in my back pocket, waiting for a crisis. Then we can jump up and say, I can solve your problem. So it's a challenge. We have to anticipate what the potential crisis is. COVID-19 was a crisis, and there were lots of money available, and lots of people were keen to look at modeling. But in the OR community, the tools we had to deal with it were fairly basic. We had to develop them. It took time. So let me give you 3 examples. So one was a successful example of dealing with a crisis. And this is in the province of Saskatchewan. So Saskatchewan is in the middle of Canada. And it's not a heavily populated province. It's around 1 million people. And it's about half the size of Iran. And so the issue that they had, this was back in 2011, And the issue they had was that the Minister of Health in the province had announced there were problems with wait times and wait lists for surgery. And so he announced that no one would wait more than 3 months for any surgery by 2014. And no one meant that 90% of people would get their surgery within 3 months. And so the minister just made this statement. One particular hospital, Victoria Hospital in Prince Albert, Saskatchewan, you can look it up on a map. It's at the top of the tree line. There's not much in Saskatchewan beyond that. I was there in January. That was cold. That was chilly. And so Victoria, the hospital, they said, yeah, sure. If you want us to have, in 3 years, you want us to get our wait times down to 3 months. The orthopedic wait times, the average wait time for orthopedic for skeleton, bones, etc., surgery, hip replacements, knee replacements, things like that. The average time was 8 months. The 90th percentile, so 90% of people had their surgery within a year and a half, 18 months. They said, if you want us to do it, we need a new orthopedic surgeon. We need more OR. We need more OR time. We need a new operating room. We need $2 million. And so we had a model developed, a simulation model, discrete event simulation model that could look at the impact of an operating room schedule and look at, based on resources and beds, et cetera, in the hospital and wait lists, we could look at how quickly people could process it. Right? And the Ministry of Health looked at Prince Albert. They said, we actually don't think you're being very efficient. We think you could change the way you're doing things. You don't need all this money, et cetera. And so the Ministry of Health asked me to bring my team up to Prince Albert and just determine whether or not they actually needed the money and determine whether they were being efficient. Right? And this is a common issue that happens between governments in a public health system, between governments and hospitals. The hospitals say we need more money. The government says you're not making the best use of it. And very little happens in the meantime. And so what happened, and I turn you back to my cartoon, you can imagine how happy the people were at Victoria Hospital to know that Mike Carter was coming in to demonstrate that they were being inefficient. Well, it turned out with our model, they were being inefficient, but they also really did need the additional orthopedic surgeon, and they needed the $2 million, and they got it based on our work. So it was very successful. It took about 3 months for our analysis, data collection, et cetera. And we discovered that if they changed the way they were doing things, that orthopedics would be fine by 2014. General surgery was currently 6 months, and it was growing. So it wasn't as bad as ortho, but they really needed to look at that too. And they had some serious bed capacity issues, and they knew that. They had to change what they were doing. So we had recommendations for how they had to change how they were doing, but they did get the money. This one, I put an X beside it. This was a failure in a sense in terms of dealing with a crisis. And it was kind of fun. I went to the Ontario Ministry of Health several years ago, and one of the leaders there, one of the directors, policy director, he said, I want a model of the healthcare system. And like the healthcare system is primarily public in Ontario, population around 15 million. And he wanted a model of the system. And after I stopped laughing and got back up, and he wanted to be able to, I said, you're going to have to be more specific. And so he said what he wanted to be able to test future policy decisions before spending billions of dollars. So he wanted to do kind of the big strategic decisions. At that time, the Ontario government had spent about $1.2 billion, so about $1 billion US, on a project called Aging at Home for Seniors. And that they did was they wanted to provide additional community services for seniors so they could reduce the demand for long-term care homes and relieve some of that stress. They had no KPIs, key performance indicators, and so he wanted to have a model. They were going through that. They had no idea what the impact was going to be. So he wanted a model that would say, if I spend $1.2 billion, what are the likely outcomes? So I gave it to a PhD student, Aliyah Sensoy, and he created a really nice validated system dynamics model. This is the causal loop diagram part of it. It's an eye chart. And pardon me. And they created a lovely model. It took 5 years. It's been published in both the qualitative model that you see here and then a corresponding stock and flow quantitative model to do high-level estimates. And we are still waiting for the healthcare system to give us a critical issue that we can look at. And so many people have been intrigued by the model. They really like it, but there's been few takers. That we waited for the ministry to try to adopt it, and we said, give us a big problem, and they said, no, you tell us what. Never mind. It was long and slow. We've had interest from Wales, from the UK, and their system was significantly different. So in fact, Wales developed their own model based on our framework. We've also been talking with a group in Switzerland looking at applying our model there. But so far, it's been a lot of work, publications, but not much uptake. Unless one that's sort of, I put a question mark beside it because it's been some success, although it didn't address the original crisis. And I had a vice president at one hospital call me, and they had an overcrowded emergency department, and they had no beds for them in the hospital. So we have a lot of this. We still do. Most of our hospitals, even before COVID, we had bed boarding problems, so that people who had been admitted to hospital but there was no bed were stuck on a stretcher in the emergency department. So this particular hospital, they decided to create a 20-bed, they called it a medical assessment unit, beside the emergency department. So instead of people sitting on stretchers in the hallway, they got admitted to this MAU, and that it worked fine. It relieved the stress in the emergency department, and that held for about 3 months. And after 3 months, the MAU was full, and they started to have people blocked up in the emergency department again. And so she called me to ask me if I thought they should add another 20 beds to the MAU. The original crisis was definitely the original question was definitely a crisis, but they needed an answer now. They needed an immediate answer. And my answer was that if they built another 20 beds, they were going to fill up, and in another 3 months, they're going to be back. This is a never-ending problem. It's not the solution. So I gave this to a PhD student, Carolyn Busby. And 3 years later, we had a model. Well, by then, that hospital had gone on to a different crisis. But it has since been used by one hospital looking at their footprint. And the model is actually based on something called surge capacity protocols. And what happens is in a hospital, when things get busy, what they do is they change what they do. So they discharge people early. They are more restrictive about who gets admitted. They may refuse. They may transfer patients to other hospitals. etc. So there's a number of things that hospitals will do to try to ease the stress. And so we built a simulation model that tells them what the impact of each one of these processes is. And it's currently being implemented at a large Toronto hospital. So the second challenge, if an OR project is going to be successful, we need to have a strong champion. We need somebody to help us out, somebody to lead it on the inside. I can't lead it. I am not leading these projects. I have to be a supporter. I have to be somebody who helps them out. And so all of my projects have a clinical or a healthcare partner. I need strong support from senior management. I need strong internal team, managers, clinicians and analysts to do the hands-on modeling. And typically I need one key collaborator. That's also the one key collaborator is also a bit of an issue, because if you have one person and they leave, then you lose your support inside the operation. So it's better to have a team. I heard one story from a hospital in Australia where they actually had 7 different CEOs, presidents. They had 7 different CEOs in a period of 8 years. So there's a lot of movement among hospital administrators. Yeah. So on the success side of having a champion, I worked for many years with a fellow by the name of Graham Woodward. And at the time, he was the director of planning for a group called Cancer Care Ontario. And like I say, Ontario is about 15 million people. And Cancer Care Ontario is an arm's length data analysis. They're not part of the government. They're an arm's length organization. Data analysis, policy advisors on all types of healthcare. It started with cancer, but then it grew to many other diseases and a lot of screening programs, etc. And Graham recognized the value of industrial engineers working in healthcare. He's hired a dozen of my former students. We've had dozens of projects with Cancer Care Ontario, colonoscopy capacity planning for looking at screening programs for colorectal cancer, thoracic surgery allocation problems, endoscopy efficiency toolkit, so many other things that we worked on. Like I say, a dozen different programs. A questionable one for a study. We did a study, a 2-year project called the Crowded Study. And the Crowded Study is, this is looking at emergency department crowding and overloading and bed boarding in emergency departments, and how are they set up and how do patients move through them, and looking at the process. And so we wanted to build a generic simulation model of emergency departments. So CIHR is the Canadian Institute for Health Research. It's the main federal funding agency for health. We went out, we got 10 emergency departments and around the province, different sizes, some academic, some community hospitals, etc. And so we wanted to collect data. We actually collected patient data. We looked time and motion studies for hundreds of patients, looking at the flow. And when we were applying for the funding, we had 10 emergency departments. The directors, the heads of 10 emergency departments agreed to participate in the study. They were enthusiastic. And so we put that into our application. Now, it took us a year to actually get the funding approved. by the time we got the funding approved and we went back to the hospitals, out of those 10 emergency departments, 5 of them had a new director and they had no idea what we were talking about. Fortunately, they all let us come in, but it was just a major challenge. We also had, I was relying on one PhD student to run the project, and he got distracted in year 3 with marriage and children and health issues, etc. And the project kind of fizzled, which was a shame. But the project design was used in a much larger study that was called the POWER study, which had been published, looking at ED physician workload. So it was questionable. And then we did some work on modeling family physician practice. And when doctors graduate in Ontario, and this is true in many countries, the doctors like to work in big centers, major hospitals, major centers like Toronto. And it's very difficult to get doctors to work in the rural areas of the province. So we have more doctors than we need in the big cities and the urban areas, and not enough doctors in rural settings. And so we had a project looking at a study, a funded research project, looking at from NSERC, which is the Engineering Research Council of Canada, and looking at a model for how we can get GPs, family doctors, general practitioners to work in rural Ontario. There were several publications. There was no champion. We had lots of interest from different groups, but there was no individual champion for the project. And so there was zero uptake, even though we had publications and it's been referenced, etc. But we really sort of missed the champion part. The third thing we need is good quality data. And this is a Dilbert cartoon. I don't know if you're familiar with it. It's a popular business cartoon, and it's quite often drawn from real submissions from people from business, I believe. So Dilbert says to his dog, he said, "I need some data from an unreachable guy named Ed. What should I do? Just make up a bunch of data like everyone else does." Everyone else does that? Are you doubting my data? That's right. Right? That's true. Okay, so the challenges, one of the big challenges for data is that, I go into a hospital and I say, I need data. And the hospital says, oh, we've got tons of data. And so I say, well, do you have this? And they'll say, oh, no, we don't collect that. And I did that for years. And I realized that hospitals collect data because the doctors need it, so they need individual patient data. The accountants, the bean counters need it. The government has public reporting that they need, so they collect things. The health records department in the hospital will keep things, but it's basically for legal support. If somebody sues you, you've got the backup. So people are collecting individual pieces for their own needs, but nobody is really collecting data on patient flow and patient movement in the healthcare system through the hospital or out of the hospital. There's very little, there's little or no links to either before hospital to the family doctor. There's no link after hospital. So hospitals rarely have data on outcomes. After the patient left the hospital, was the operation successful? They'll do things like, 30-day readmission and things, a few simple things, but basically the patient flow data is fragmented. It's not, it's very difficult to get. One silly example, I had a hospital, we were looking at the emergency department and we were looking at patient flow in the emergency department. And we were very excited because they actually had one of the data elements in the data set was what is the current location of the patient, so the patients can move to different areas of the hospital, of the emergency department. And then when the patient moved, they overwrote it so that the patient location, it was the observation area, which is the last part. So they had all this great data, but then they threw it away. They didn't save it. Healthcare is one of the few industries that actually still uses a fax machine. I don't know how popular fax machines are in Iran, but the fax machines are basically not used in other industries except for healthcare and some in finance and banking. But fax machines are a terrible way to, the data is unreadable in terms of data collection. Paper gets lost, fax machines run out of ink, and so the thing doesn't print properly, etc. But we continue to do it because every doctor's office and every hospital and every pharmacy has a fax machine. So it's a huge effort to try to get it to change. The data issues in hospitals, I say it's our fault. And I always complain about people not collecting process data. But I think that it's, we as industrial engineers in healthcare, we should be defining what it is that we need, what it is people need in order to, what data should you be collecting? We should be defining a minimum data set. And again, 3 examples of data issues. We had a major project 10 years ago looking at how many cardiac surgeons does Canada need in the next 10 years? And so we've been asked by, we had our champions because we were asked by the president and the vice president of the Canadian Society for Cardiac Surgeons. So they were leaders in cardiac surgery in Canada. We had a new crisis because what was happening was that the demand for cardiac surgery over the years has actually been dropping, and this has been international. And cardiac surgery is where they break open your chest and stop your heart and do, put you on a heart-lung machine, etc. So it's a very major surgery. And what's happening is that in the cath lab, the catheterization lab, so a lot of the surgery that used to be done for things like a valve, a bypass surgery for an artery that got plugged. Now they just stick a catheter up an artery, and they'll go in, put in stents. They'll put in balloons to open up areas, and so a lot of heart surgery that was required no longer needed, no longer necessary. So the demand has actually been dropping. So the demand for new cardiac surgeons has been dropping. New grads are having trouble getting a job. And because the new grads can't get a job, students in medical school are not signing up for cardiac surgery. And so the Canadian Society of Cardiac Surgeons was worried that in 10 to 15 years, it takes 10 years to train a cardiac surgeon. So if you don't have enough people signing up today, in 10 years, you could have an issue. And so we had strong champions, and we were looking at, and we had excellent data. We had years of data on every cardiac procedure in Canada. I knew the age of every cardiac surgeon in the country. There were 160 different cardiac surgeons, and they all worked out of heart centers. And we had surveys of residents and fellows who wanted jobs, so people who were in the market. So we knew what the demand was. We knew we knew how many cardiac surgeons we were going to get for the next 10 years. And so we built a system dynamics model looking at that. It was excellent data sources. And we also, when we did it, we also discovered that the end result was that, in fact, 50% in the next 10 to 15 years, 50% of the current surgeons in Canada would be retiring. Cardiac surgeons retire in Canada at around 65. One of the cardiac surgeons told me that the reason for that is what they call the on-call. And the on-call is the surgeons have to take turns, rotate through on-call, being allowed, you can get called in the middle of the night, get down to the hospital in 20 minutes, we have an emergency. And that just gets too much for people. So they move on to other things. Perioperative DES simulation model. So this is the same model I talked about at Saskatchewan. We have implemented this model in 15 different hospitals. The hospital tells us what the OR schedule is, and we populate our model with random patients. We use real patient data. And it's interesting, the results actually of our simulation model never actually match reality. People do not follow their own rules. So, they'll tell us that an operating room starts at 8 o'clock in the morning and it finishes at 4 in the afternoon. And when we look at the actual, they start at 8:30, 9 o'clock, they finish at 4, 5, 6, whenever, right? And it's so when we run our simulation model, sticking to those 8 hours, the results we get in terms of the number of procedures that are done are different from what's actually happening. And they tell us rules about which surgeries they're going to do. And they tell us rules about how they manage their wait list, and they don't. So the perioperative simulation model requires a huge amount of data, and it's a challenge getting the data and getting it used over time. And then the Ontario Health System model, so the one I showed you earlier, so that was from the issue of finding a crisis. It's also an issue in terms of data. So the goal was to estimate the impact of major capacity changes. This was our system dynamics model. Some of the data is based on recent policy changes. Mostly it relied on expert opinion. A lot of the things in our health systems model were not data that was collected routinely. And so we had multiple expert panels from different sectors to populate it and say, well, what do you think? What do you think would happen? And what do you think the capacity is for this service or that service, right? And brought in multiple expert panels from different areas. It was a major challenge. So it has enormous data requirements and interpretations to make the model very difficult to implement. And as I said, it's been a challenge getting anybody to actually sign on to it. The fourth challenge that I talked about is just the healthcare culture itself. So in healthcare culture, it's very difficult to make change, to make differences, to make an improvement. This cartoon, I want you to find a bold and innovative way to do everything exactly the same way it's been done for 25 years. And that's not a joke. That, unfortunately, is people are very unwilling to change and move. Okay. And here's the idea: healthcare innovation. One of the huge challenges in healthcare is that no one is in charge. There's nobody, in a public healthcare system, nobody's actually running the ship. I have a joke that says that if I went to a large company, a private company, and I said, I can save you $1 million a day if you use my model. If the CEO of the company agreed and believed it, then the CEO would make it happen tomorrow. And I've talked to CEOs of hospitals, and they say, Mike, I love your stuff, but this is this is I'm going to have to we're going to have to talk about this. We're going to have to discuss it with people. The CEO of a hospital is not in charge, does not make the rules. The CEO is a facilitator. So the CEO will bring together people. All right, let's all agree. And all of these issues, so the government, science, the doctors, education, industry, inventors, ethics, the patient, startups, nurses, the payers, they're all pulling in different directions. They all want healthcare innovation, but we're not getting anywhere. Because for everything one person wants to do, somebody else does not. So it's very difficult to find a compromise. And so there's a lack of a single decision maker. And so you say, well, what is the objective of our operations research models? What is the objective? And my answer to that is that I think we have to come up with solutions that actually are better for everybody. And now, fortunately, in healthcare, things are typically so bad in healthcare that it's always easy to find a solution that is better, or at least no worse, for everybody. So it has to be better for the doctors and the nurses and the bean counters, the costs, the administration, public opinion, government, decision support, perception, and maybe even for the patient. Okay. There's just not many examples of real team effort on problems within healthcare. And there's this paper years ago, Gluberman and Mintzberg, and Henry Mintzberg is a famous healthcare industry guru, and Shalom Gluberman he's a philosopher. He calls himself a healthcare philosopher, and they created this model called the 4 Faces of Healthcare. And in their model, they created a model so for a hospital, and they said there's 4 major stakeholders, and the stakeholders are the doctors and the nurses and the managers and then the trustees, the board of directors, etc. Right? And the doctors provide cure. So the doctors will come in and see a patient on rounds, 5 minutes, 10 minutes, on a weekday, and they'll come through and they'll, prescribe drugs or order surgery or do something and leave, move on to the next patient. When the nurses are providing 24/7 care. So the nurses are there all the time. So they're providing consistent care. The managers are trying to control everything, the administrators and the managers. And then the trustees represent the community. So the trustees are looking at the interest of the community, both financial and providing the services that the community needs. You'll notice that there's no patients on this stakeholder thing. The interesting thing is the coalitions. The clinical coalition, the doctors and the nurses are the only ones who actually see patients. The board of directors and the managers don't see patients. They don't work directly with patients. The insider coalitions, the managers and the nurses, it turns out that the doctors do not typically work for the hospital. Depends on the system, but in Canada and in many other countries, the doctors are private entrepreneurs. They have admission privileges in the hospital. They can bring their patients in. Once they get admission privileges, etc., doctors do not work for the hospital. So the managers and the nurses are the insider coalition. They actually paid for and they work in the hospital. The containment coalition, the trustees and the managers are trying to contain things. They're trying to control the budgets and spending and how are we going to allocate, etc., and doing the planning. And then the trustees and the doctors are the status coalition. That's the fun one. None of these people work for the hospital. The trustees and the doctors think they're in charge. They're running the show. You can't do anything in the hospital unless all the doctors agree that that's a good idea, right? So if you tried to run a company like this with this setup, it would never work. The reason it works this way is I do not want my doctor to be answering to an MBA CEO. I want my doctor to have my interests at heart. So it's this patient care. It's the the direct patient responsibility. I don't want my doctor to. When I'm sick, I want my doctor to do everything for me, everything reasonable. I don't want him to say, "Well, that's too expensive. We'll do something else," right? So the doctors are not tied to the budget of the hospital. The doctors will decide with all the patients who goes first. They will decide on priorities, etc., but they will not. They're not affected by the cost. So let's look at some in the healthcare culture side. I'm going to look at some positive and negative and questionable issues. So my perioperative simulation, in particular, my perioperative simulation. So what I want to do is I want to try to revise the operating room schedule, change, so what happens in Canada and many other places is that a doctor will have a schedule that they will get every Monday and every Wednesday. They get operating room number 4 all day long, and they bring in their patients. And so it's their patients, and they directly bring them in. Now, one of the problems is that the doctors in Canada typically work Monday to Friday, and so by the end of the day, the end of the week, by Friday, the beds are starting to fill up, and then they empty out over the weekend. By Monday, we're low, and virtually every hospital I've seen has the same problem. I can change the doctors. I can move doctors around in the schedule because some doctors are just doing outpatient surgery, and some doctors are doing a lot of people who need a bed. And so they have different resource requirements downstream. So I can change those resource requirements and balance the use. And the interesting thing is that by changing it, I can actually make it, efficient use of resources. I can make it better for everyone. So I want the doctors to move. I want now by moving them, because the beds all fill up by Friday. On Friday, the hospital has to cancel surgery. Well, the doctors are paid fee for service. So if their surgery is canceled, they don't get paid that day. So there's an incentive for the doctors to have a balanced schedule, better use of resources. There's an advantage to the nurses because the nursing wards are crazy on Friday and half empty on Monday. It's better for staff. It's better for the doctors, etc. So it is better for everyone. It's probably better for patients. Okay. Efficient use of resources, better for the bean counters. So that's an example of where I can actually create a solution. And I have to go through that. I do a checklist and say, all right, if we implement this solution, who is going to benefit and who is going to be worse off? And if I come up with a solution that's not good for the nurses, it will not work. It'll fail, and nobody will know why. We had one model that we were doing in Winnipeg, in the province of Manitoba, and looking at orthopedic wait lists. And in orthopedic wait list modeling, we created a really simple Excel tool to estimate patient wait time. So somebody needs a hip replacement or a knee replacement. We have wait lists of our standard is people should be done within 6 months. And the doctors don't like to give patients a date because there may be urgent cases that arrive in the meantime, and the doctor has a fixed amount of operating room time. So the doctors don't like to give people a date. So you just say, you're on the wait list, you go home and sit by the phone, wait for the doctor to call you. So we developed a simple model that says, well, the wait list is fixed, people first in, first out, and the emergency arrivals, the urgent emergent arrivals, is a random process. Most of them are fixed in ahead of time. And so we developed a model that would give patients a window for their date. We say, well, right now it's February, so We expect that your surgery will be in September. And then in June, we'll say, well, it's actually going to be in the middle 2 weeks of September, et cetera. And by August, we'll give you a specific date. And we were kind of nervous. We put this in, and we were kind of nervous about whether the surgeons would like this or not. Well, the surgeons were quite happy with it. And it turned out that the scheduling assistants were reluctant because there was extra input data that was required to support our model. We tried to convince the scheduling assistants that these people sitting at home are calling in to say, what happened? When am I scheduled for? What's happening to me? And so we tried to convince them that things would be better, but it was interesting that the pushback, and we didn't actually go through that list of, well, who is this affecting and how, and try to sell it properly. And a questionable one, like the surgical simulation model, looking at our discrete event simulation model for scheduling for surgeries. We had one hospital, OR planners, they were looking at rebuilding, and they were trying to decide how many operating rooms they should have in their hospital for the future. And they had a steering committee set up that had multiple stakeholders. And the chief of surgery just got hung up on, we had a discrete event simulation model looking at the future and wanted to know how we validated things before we actually modeled it. We weren't looking at any output. And he just got hung up on validations. And clinicians get anchored into what's randomized clinical trials. You know, you want to try one group with and one group without, and with a drug and without a drug, et cetera. In reality, I once read that 20% of medical interventions are supported by randomized clinical trials, but that's the gold standard in medicine. And we couldn't do this, and so our efforts eventually just got lost. It's a shame. Just so you know, Dr. Cotman can be a bit condescending at times. You see doctor coming in on it, and yes, that happens. And finally, my fifth one, I'm going to close soon here. I'm looking at the other challenges, managing expectations. And it's really tricky to manage expectations in a hospital, in a healthcare environment. People generally do not understand what we mean when we talk about we're going to build a model. They all think they do, right? And they all have different ideas, and they don't understand. So models, if people are looking for predictions of the future, well, models are not predictions. Models are scenarios. If you follow, we've got a long list of assumptions, and if all of these assumptions are true, then modeling outcome appears highly likely, right? And people don't understand that. And we need to. I hope that my models are close to reality once we get the assumptions right. People want one model for everything. They want a simple model. They use linear regression, and there's a story in Ontario, in my province, where they built a model of nurse demand, how many nurses we're going to need in the province. And the model, if you followed it through, it used linear regression based on the demand for nurses. And if you followed the model, it said by the year 2050, everybody in the province of Ontario would be a nurse. There were cuts in the 1990s, and then there were efforts after 2000 to try to catch up. And so if you followed that line, the straight line approximation just went crazy. Other examples include linear fit on the incidence of disease. If you have diseases that are decreasing recently and you do a linear model on it, if the disease will be eradicated in no time and eventually go negative. It doesn't make sense, right? So we have to be careful with models. For some problems, linear models make sense, but we really have to be careful about the assumptions. I'm going to skip that one. The PDF didn't show up. Sorry about that. That was just an example. Okay. And my whole system model. So here was an example of where modeling expectations did not work. So in this case, this was my whole system model. So the sponsor actually wanted his expectation when he asked for a model of the healthcare system. He wanted a model. With the Ontario Ministry of Health, there are 100 people in the ministry who do nothing but policy analysis. Like, if we do this, what's the likely outcome? And so the guy who asked me the question, he was hoping that we would have a little desktop application that policymakers could use to stick in, if we spend this much on that, what's the likely outcome? And, our model sort of does that, but it's a lot more complicated than that. It's a lot trickier than that. And some of the quotes, George Box, all models are wrong, some are useful. Einstein, a couple of quotes, make your theory as simple as possible, but no simpler. And then for my healthcare problem, every complex question, there's a simple and wrong solution. And I don't think people appreciate that, how bad things can be. In terms of managing expectations on the positive side, we had a problem we looked at several years ago. One of the hospitals for cardiac surgery, Hamilton Health Sciences, is down the road from Toronto. And they were building a new cardiac operating room. They had 3 and they were building a 4th. They were putting in no new cardiac beds and no new cardiac intensive care beds. And they wanted a master plan, a master schedule. So how are you going to do more surgeries? How are you going to rearrange the doctors on the surgeries and build a master schedule for when the doctors operate and get balanced demand for beds and for intensive care? And so we built, this is one of the first ones, we built a discrete event simulation model. I had a master's student build a simulation model to try to look at different ways the doctors would be scheduled, what impact that would have on downstream resources, nurses, beds, etc. And the chief of surgery at that time, the chief of cardiac surgery, Dr. Kevin Teo, and he was kind of skeptical about building a model to do it. But he actually worked very closely with my master's student, Jane Young. And after a couple of weeks, he suddenly got the light. He understood what we were trying to do and what the model did. And we used to have these meetings, and we had one meeting one morning with all of the surgeons. So there were 5 surgeons, and they were all present. And I remember distinctly, there was one doctor across the table from me, and he was asking me a question, but he was wagging his finger at me, like, you don't know what you're talking about. And he asked me a question with sarcastically. And before I could say anything, Kevin answered the question correctly. Everyone stopped complaining immediately. There wasn't a word, that Kevin understood what was going on. Another example of managing expectations, we did a modeling for orthopedic surgeons in Canada. How many orthopedic surgeons do we need, and what's the wait list look like, and how are things going? And the data was tricky because there are so many orthopedics. Every hospital has several, and it was kind of tricky to decide what you need or how many. In 2011, we told Bone and Joint Canada, the group we were doing the modeling for, that there was a major shortage of orthopedic surgeons. And 2 weeks before we did that announcement, there was an article in the Globe and Mail, which is the national newspaper in Canada. They had a story that said new orthopedic graduates cannot get jobs. And so people looked at me and said, how can you say there's a shortage when these people can't get a job? Well, there was actually and it made me actually revisit and rethink things. Both of these were correct. They couldn't get jobs. And the reason they couldn't get jobs is because the governments were not funding it. The hospitals were not willing to give operating room time. So there were long wait lists, yes, and there were surgeons available to do it. but there was no operating room time. And in particular, for some of the less important areas like neck and shoulder, hand, foot surgeries, etc., were difficult. And then OR and the COVID pandemic. We just look at operations research, and do we have look at my five different challenges. So one, we definitely have a crisis. Two, we have plenty of champions, lots of people looking for operations research modeling and looking what the impact is going to be and how are things going to be down the road. Plenty of research funding available. And of course, now everybody is doing pandemic modeling of some description. The data, well, not so much. There was no previous pandemic quite like it. People go back to the Spanish flu of 1918 to get data that's even close, and things have changed dramatically. Healthcare culture was fascinating because you've got, scientists, the scientists don't agree. The scientists are fighting about what happens, and public health is trying to manage things, and the politicians are making decisions. So managing expectations is a real challenge. So has OR helped the COVID-19 pandemic? Absolutely. And again, more on the operational side than on the strategic side, et cetera. And there's just a lot of reasons for that. So it's still, even after 2 years, it's still a huge challenge. So what do you think about my challenges? Do you agree with my list? Do you have challenges you'd like to add? What's your experience? Do you have any of your own examples? I would love to hear from people. Oh yeah, and then my final cartoon here. So the professor at the board, and he's got this long equation in the middle. It says, then a miracle occurs. And the other professor says, I think you should be more explicit here in step 2. So I call this Mike Carter solves the healthcare problems of the world. And that's what I'm waiting for, is a minor miracle. Okay, thank you very much.